Tavio, I'm long-winded. Signal me when it's time to sit down and shut up. You're going to do it? All right, all right. I have all the confidence in the world in you. I would like to thank you for being here, for your concern for those who need our assistance, especially for your concern for rural America, a part of this country that is so vital to all of us, but that is underrepresented because it doesn't have the population that the urban areas have. I love being executive director of a rural health association. Now, why is that? Because we have an agenda supporting what is best for rural Alabama. We don't have to look only at hospitals and support what's best for hospitals, or physicians, or nurses, or cattlemen, or truckers. We support what is best for rural Alabama. So we border on being an association without an agenda, or certainly without a selfish agenda. I always point out two things to groups before I speak to them. The first, I kind of learned the hard way. About 8 years ago, I learned that everyone does not have an appreciation for rural areas. I thought they did. So I was speaking to groups and publishing studies, not knowing that many of my pleas were falling upon deaf ears. I challenge every audience that I speak to get up and touch anything real that wasn't either produced in a rural area or produced using materials or resources that originated in a rural area. I'm sure this can be done, but it hasn't been done in 8 years. We all need the rural areas, those heroes who live and work in the rural areas, and the materials and resources that come from those areas for our survival. Think about this food over here. None of that was grown in Times Square. It was all grown in rural areas. So I like to point that out before I speak, just in case there's someone who doesn't realize how important rural areas are to their being here. Another thing that I like to point out, and I think this is true everywhere, but here in Alabama, we are struggling to keep our healthcare facilities open tomorrow. We haven't taken the luxury of developing a long-term plan. What is the long-term plan? 2 years ago, I conducted a study to give me the evidence that I needed for something that really was common sense. But even if you know something, until you have the data and evidence to back you up, you have a weak argument, or not as strong as it could be. We all know that there is a very close relationship between educational attainment, income, and health status. It makes sense. But what I did, I studied Alabamians aged 25 and over. Now, why 25 and over? By age 25, most people have completed their education. Now, there are a few, like old Dale here, who goes back and gets a master's degree in his 40s. But for the most part, by age 25, most people have completed their education. We're not skewing or distorting the study by including those who still are working on their education. The years of education are on death certificates. So I calculated mortality rates or death rates for Alabamians aged 25 and over by years of educational attainment. Those with less than a 9th grade education have a death rate 2.25 times those with a high school education. And those with a high school education have a death rate more than double those who have any college at all. Now, I made certain that I did not have a confounder here. You would think those who are older, say 85 and over, would have attended school at a time when they would have been less likely to get a high school education. I looked into that, and actually the age 85 and over, who are referred to as the oldest old, that's the term that's given for them, just like elderly is for 65 and over. Actually, they had the second highest percentage of college graduates among all of the age groups that I looked at. Those who had less than a ninth grade education apparently have already left us. Most of them have. So the long-term solution for health care is a better educated population. That is long-term because you can't snap your fingers and all of a sudden everyone has a better education. But there are things that we can do, some things that have been mentioned today. We need to expand greatly in Alabama and probably in your states too, tele-education. Bring those special teachers out from the confines of their classroom and share their talents with public, private, parochial, and even home-based students. Also, you can offer courses that many schools, like the one that I went to that had 315 students in grades 7 through 12. Forget junior high school, there wasn't any such thing. But you can offer courses for the rural students that they could not think about having the faculty to offer. Now there again, just like with telemedicine, which I'm going to talk about later, we need universal broadband coverage for teleeducation as well. I'm changing my presentation considerably because many of the things that I was going to talk about have already been discussed today, and it'll be a waste of time. But I do want to give you a few things to consider, to take home with you and think about. What we have here is a picture, a graphical picture of racial and geographical disparity. This is age-adjusted mortality rates, all causes of death for 2015. Age adjusting removes age difference in the populations as a factor. So what we're looking at here is not the difference in the composition of the age of the population. This presents white and black Alabamians and white and black Americans, national data. You can see the racial impact here. White Alabamians have a death rate that's considerably, significantly lower than that for African American Alabamians, and the same nationally, only the impact nationally is greater than here in Alabama. You also can see the geographical impact. Both racial groups have higher death rates in Alabama than the nation. Interestingly, the African American population nationally has a lower mortality rate than the white population here in Alabama. We have a very unhealthy population in this state. What population is left in this state? One thing, one sure sign of an unhealthy population is when you don't have healthy population growth. We have 67 counties in Alabama. 24 of those counties, all rural, had less population in 2010 than they had 100 years earlier in 1910. 5 had only 1/3 of the population in 2010 that they had in 1910. What's more discouraging is the fact that if you look at population projections for counties from 2010 to 2040, 41 of the 67 counties are projected to lose population. Guys, this is not going to work. What this means is that we are not having the economic opportunity and growth in our rural counties that we must have. Our children are going off for college or technical training or the military and are not able to come back home and have a career and be there around us when we get old and want them there and need them there. That's not happening. This must be reversed. And part of that economic cycle of necessities that you must have is adequate and quality health care. I was invited to come to Birmingham and speak to officials with the Economic Development Association of Alabama 3 years ago because for 3 consecutive times they were trying to recruit businesses into smaller communities and lost out because there was not adequate health care locally available for their future employees. It's kind of like a vicious circle, the chicken and egg thing. You need the economic opportunity and population growth in order to attract the health care. You need the health care to attract the economic opportunity. I want to go over a few specific health disparity indicators with you to let you kind of think about it, because I love to look at data and start thinking, why? Why is this happening? This particular publication entitled Selected Health Status Indicators, Alabama's Caucasian and African American Populations, I developed in 2013, so it's a little outdated. But in my previous life, I was Director of Statistical Analysis with the Center for Health Statistics here in Alabama. So I'm one of those people that believe if you can't say it with a number, it's worthless information and you don't need to know it. But I was invited to speak at the annual conference of the African Methodist Episcopal Church at Troy University and to identify health disparities, to identify significant health issues among the members of their congregations. They're quite active in trying to improve the health status of the members of their congregation. So I developed this publication that looks at over 90 health-related indicators comparing Alabama's black population to the white population, to the national black population and national white population on these 90-something indicators, allowing for quite a bit of cross-analysis. Septicemia, blood poisoning. Alabama has the 3rd highest death rate from septicemia among all 50 states. Why? This begs for research. If you look at Alabama's black population, that rate is 26 deaths per 100,000 standard population compared to 17 for white Alabamians and compared to 18 for black Americans. Why is there that difference? Prostate cancer among males. Again, I'm looking at mortality here. Alabama has the 3rd highest death rate from prostate cancer among all 50 states. The rate among black Alabamians was 59 per 100,000 standard population compared to 17. 59 to 17 among white Alabamians and 37 among black males nationally. Why? Why? If you look at the incidence of prostate cancer among black males here in Alabama, you will see that difference between black males and white males, but it is not that great. That tells me that we have a major problem with either no diagnosis or late diagnosis. Diabetes. Among black Alabamians, the death rate from diabetes is 40 per 100,000 compared to 17 for whites. That's how much time I have left? Oh my God, and I haven't started. Okay, let's forget this. And let's go on to the end of my presentation. I told my wife instead of 18 minutes, I needed 18 hours. What steps what steps can Alabama take to address healthcare issues in our rural communities? We need to expand Medicaid first. We must expand Medicaid But if we improve education to the point maybe 20 years from now, we'll wake up one day and say, what in the world are we doing with all of this Medicaid that we don't need? Because we have a better educated population living healthier lives and earning a higher income. We need to expand the use of telehealth and telemedicine. Alabama does not have parity legislation. Georgia, Tennessee, and Mississippi have laws mandating that telemedicine be reimbursed by private insurance. We do not. We don't have that. We need to be a leader in telemedicine rather than a follower. Our largest insurance company in Alabama does voluntarily reimburse for 6 major types of telemedicine care. We need to change the rules and regulations and allow our mid-level practitioners to do what they're trained to do and can do. Alabama is one of the most restrictive states on what mid-levels are allowed to do. I called a hospital CEO a couple of years ago in Leakesville, Mississippi, fairly close to Mobile. This is a county with not one physician in the entire county. Their emergency room was staffed by 4 nurse practitioners from Mobile, Alabama, who drove over to provide service in Mississippi that they're not allowed to provide in their home state. We're really losing out on quality care, especially in our rural areas. We need to authorize a new type of hospital or emergency facility, more so in Alabama than most other states. We have an antiquated requirement that a hospital cannot be licensed unless it has 15 or more beds. Guys, that came into existence back when a physician could send anyone to the hospital for anything and leave them there as long as they wanted. The hospital that I just mentioned in Leakesville, Mississippi had 3 beds, a 3-bed critical access hospital with 54 employees, and it was operating at a profit. There was a hospital, unfortunately, I hear this hospital is struggling now, but in Mountain City, Tennessee, a 2-bed critical access hospital with 70-something employees operating at a profit at that time. We're going to have to change our requirements to allow small bed count hospitals in areas where it will not threaten other hospitals. 84% of all hospitals in the state of Alabama, including rural and urban, are operating in the red right now. So the Hospital Association, rightfully so, does not want to establish new hospitals to take business away from those who are already losing money. But there are things we can do to go ahead and authorize that capacity and that capability when we get around to needing those types of facilities. We need to assist our rural areas in economic development. And what we need to do first, not only do human beings need to do this, but I view geographical areas the same way as being living entities. There needs to be a self-assessment of the area. Take a look at what you're good at, what you have, and then determine where you need to go in economic development. We're talking about the Black Belt area. Most of what you hear is we need an automobile manufacturing plant in the Black Belt. The Black Belt has that rich soil. It is still there. Only so much of the acreage is being converted from crop and pasture land into forestry, which is a long-term crop of 15 years. We need to look at the possibility of cooperatives, agricultural cooperatives, to allow the small landowner in the Black Belt counties to get a piece of the pie. We also need to look at our rural areas and all that they're contributing. The Black Belt counties produce most of the catfish in the United States. They're the most productive forestry area in the state of Alabama. One other thing that we need to do, and the Alabama Rural Health Association is working on this, we have talked about getting local people involved. One thing I learned from when I talked with the members of the African Methodist Episcopal Church in Troy, is what churches can contribute. Now, when I say church, I'm talking about churches, temples, synagogues, mosques, only I don't want to say that every time. So when I say church, I'm talking about all of them. I get calls every month from various programs or entities who want to conduct health education events or screenings or fairs in rural areas, and they ask, who do we need to partner with to reach the people who need to be reached? The churches. People trust the churches. Members of the churches know the people in their community, even if they aren't members of that specific church, and will have them there for the health educational event or screening. We got a small grant, and when I say small, it's $5,000 from the Caring Foundation with Blue Cross and Blue Shield to develop an online church registry. We have a whiz kid up in Huntsville who's writing the programming now. You can't use a drag and drop service for this. It's going to be password protected. Churches can go in and register their facilities as possibly being interested in health education events or screenings or fairs. We ask a bunch of questions to identify those that can have the capability of hosting such events. Entities like schools of nursing who would like to provide such training or such events will contact us and say, look, we want to provide this opportunity in rural Fayette County. Do you have any churches that we can work with? We go to the database and we contact the churches and say, this opportunity exists, are you interested? And then we link them together. This is being developed right now. We also are adding 2 bulletin boards. A bulletin board where the church can post a notice and say, we're interested in someone who can offer training in how to cook for someone who's diabetic. If you can meet this need, please contact us, and we'll have exactly the same bulletin board for those who offer such training, soliciting churches that they can work with. This is being developed right now, but it has already been very positively received by the Southern Baptist Convention for the entire state of Alabama, the same for the Methodist, Catholics, and the Church of Latter-day Saints. So be checking the Rural Health Association's website for this in the future, and we're going to try to utilize this resource to a better extent. One other thing, and I'm going to be quick. I know I'm already past my time. We are working with the Alabama Department of Public Health to establish county health coalitions. The idea for this came from Escambia County, which is right on the Alabama-Florida line. They lost a hospital back in the early 90s, and responsible people became very concerned about the health and future of healthcare in their community. They created this coalition with members from the 2 remaining hospitals, the Indian Health Service, which has a clinic in that county, physicians, nurses, mental health, public health, EMS, dialysis, local government, the clergy, education, law enforcement. They brought people representing the entire community together to better identify what the healthcare related problems were, what the needs were, and what possible solutions were. This organization was created back in the early 90s. It's still going on today, having monthly meetings, and they have provided some great impact. Kid One Transport offers free transportation to women and kids in Alabama who can't afford EMS service, especially by helicopter. They lost their grant funding and had to get out of providing service in Escambia County. This group went together, and having that group, that compendium of different interests together, gives you much more influence in getting funding locally from businesses and foundations, but nationally and statewide also. You're not just one entity, you're a voice of the entire community speaking. So you don't need money to start out, but this coalition can give you the influence to get money. That group went together and in no time bought their own ambulance and driver and replaced Kid 1 transport in the county. That's all I'll cover right now. Sorry for not getting hardly anything out, guys.